Good evening, everyone. Respected Chair, Kamal Sir, my co-speaker, Dr. Suresh Damodar, and all my friends here. Now, my job, I think, is very easy. Statins for all diabetes, are we justified? And I am talking for the motion to say yes for that. Now, I know this is a very sensitive topic, and even there might be people in the audiences who are on statins, and people have their own experiences to talk about, which is something that happens when a medicine has been used so much. Statin is one of the most commonly prescribed medications, and people are bound to have side effects, and that obviously will lead to a difference of opinion. So my job today really is to support the fact that the advantages of statin far outweigh the risks that it would cause people with diabetes. Now let me just state some facts. We know diabetes is an epidemic. The progress is unabated. I think we have underestimated the numbers. I mean, we have seen that in all the WHO numbers that they talk about. Every 10 years there's a projected number, and that keeps on increasing, doubling or quadrupling as time goes on. That is because people are living longer with diabetes. So the prevalence of diabetes, along with the incidence, which is also rocketing, the total seems to build a huge population of people with diabetes. The cardiovascular risk is dramatically high in patients with diabetes, and this is a fact, and I will hopefully show you some evidence for that. The statins' survival benefits in high cardiovascular risk patients have been proven beyond doubt over a number of decades. And I would propose to you that statins are safe for long-term use, and I'm sure my friend, the co-speaker, will have a few things to say about that. But I feel there is convincing evidence from studies to say that you have to use, or at least you have to consider statins in all patients who can tolerate it, in all people with diabetes. Now, let me introduce my friend. I mean, this is, I'm conveniently calling him Mr. SD. I will just show the next slide. So this is perhaps, so he is somebody who developed diabetes at the age of 40. Now, many of you would have seen this movie called Sliding Doors. This came about 2 decades ago. If you're not aware of it, you probably would have seen the movie called 12C. 12B, that's a Tamil movie. Now, this is where the slide, where somebody's life changes just because he makes one decision at one point. So how the life parallelly goes in 2 different directions just because one decision is made. So I think I'll come to that later. I'm just introducing that. Please keep that in mind. Now, so this gentleman has developed diabetes at the age of 40. Okay. Now, what more do we want? We have such a big study, such a wonderful study in terms of UKPDS, which clearly showed that there are 3 major risk factors for diabetes in terms of cardiovascular risk. And they are the dyslipidemia, the systolic blood pressure, and A1C. So this has been, this has been there for a long time. Now, what we are saying there is that the LDL cholesterol or the dyslipidemia is the strongest factor in terms of the estimated hazard ratio. And the LDL level seems to predict the highest people risk for CVD. Now, this has been questioned since then, and we'll come to that later. But what we are trying to say here is, even at the stage of pre-diabetes, there is lipoprotein abnormality, there is dyslipidemia. This perhaps is one of the reasons, I'm not saying it is, but perhaps one of the reasons why cardiovascular disease is higher even in pre-diabetes, as you very well know. Now, we know about the quantitative changes in LDL. The absolute value of LDL might be same. However, it could be more atherogenic, and atherogenic, we know about the small dense LDL, the atherogenic LDL, which will increase the cardiovascular risk. We also have data from Framingham, which has said that diabetes, I mean that's also a large study as we know, diabetes has to be a 2 to 4-fold increase in CHTN score. Now, if you have diabetes and then develop a CV event, actually your prognosis is even worse. So that points to the question whether we should look at primary prevention, because clearly your risk will increase if you have diabetes and then have a CV event. So it just shows that there's so much incremental evidence for diabetes, dyslipidemia, and association with cardiovascular disease. Now, this is what led to the very seminal paper by Hafner, which pointed diabetes as a CHD risk equivalent. What it meant was that the absolute risk of the first CV event for somebody with diabetes is equal to the same risk that somebody without diabetes would have after the event. So the second event, obviously, once somebody has had a heart disease, the second event chance is much higher. But if you have diabetes, then that is equal to that. So that means, in simple terms, diabetes is equal to 1 cardiovascular event. So I think that is again been shown in many studies. And this is that Hafner data, and you can see those two groups closely linked together. So that is the one with no diabetes who have had MI, but those with diabetes without MI, and the risk is same. And there are other studies that have shown that. If you look at the Nurses Health Initiative, that's again, there was clear evidence that the diabetes would be considered as a CHD equivalent. There is a study from and Paisley and Women's Food Project. So the number of studies that have shown pretty much similar results to the Hafner paper, saying that you have diabetes, it's equivalent to having 1 heart attack. Okay, so add to that is the fact that 2 out of 3 with diabetes, more than 65 years, will die of CHD. Now, what would be such an important thing to consider? Now, all that I have said doesn't mean that statin is going to be useful. So it just means that dyslipidemia and diabetes and CHD are associated. It was performed by a GP from UK, and there, that was in 2008, so about 7-8 years ago. There were a lot of questions asked about how the statistical analysis was done. That is a risk, yes, that is there. But that is not a reason not to use memory problems. And there have been a lot of press and a lot of negative press around this. There is really no convincing evidence to look at, and I'm sure my friend will address that later. The cancer risk, again, absolutely no evidence. So if you look at any meta-analysis, any data, there will be 1 or 2 studies, which is bound to happen because it's an area that's been studied quite significantly, different statistical analyses have been used, and there is bound to show 1 or 2 studies that might come up with this negative thing. But if you analyze all those data together, there doesn't seem to be any convincing evidence to say that these are a major problem with statins. So I would like to say that the benefits far outweigh the risk of this agent. So what happened to our young man or old man or whatever you call it? I said he developed diabetes at the age of 40. He decided not to take statins. So that is for primary prevention. That is a very reasonable decision. But he developed the first cardiovascular event at 50. Now this is not evidence-based, this is just emotional blackmail, you can call it that way. He still didn't take statins because he had muscle aches and he didn't want to take statins. So that was secondary prevention. Now that was getting pretty serious. He had another event at 60 and he died unfortunately a couple of years later. Now, what if he had taken the other sliding door and gone on to the other side and taken statin? This gentleman decided to take statin from the start, from the age of 40. Yes, he had some mild muscle aches, so he had to reduce the dose. He had a cardiovascular event, which was a mild one, which was 20 years later. He's age 70, good quality of life. He's still around. He has seen his children and his grandchildren growing up, and he's still living a very purposeful life. I think that is probably what the statin really is. So, ladies and gentlemen, in summary, I would like to put in front of you that unless contraindicated, evidence points to treating all patients with diabetes with statins. Periodically, we need to assess their risk to consider perhaps escalating the dose or changing the dose, going for a high potency statin, perhaps even reducing it if you're not convinced about the second approach. The benefits of statins in reducing CV risk far outweigh the risk that has been put in front of us. Any decision we make in medicine is like a double-edged sword. That we all know, we have all practiced enough. But in this case at least, one of the swords seems to be awfully not sharper than the other. Thank you.